Hello, it's Ted Ritzer. I'm the host of the Greening Government webinar speaker series, and today we're going to have a couple of great presentations on the topic of telehealth. The speaker series is a collaboration between my department, Alberta Environment and Parks, the Alberta Climate Change Office, and the Municipal Climate Change Action Center. These presentations today will be posted to our partners' YouTube channel. And it was interesting on this topic of telehealth. I was doing sort of some Google searches and came across actually Stewart Ferguson's several of his presentations where he talked about the use of telehealth within the state of Alaska. And I really zeroed in on some of the slides that talked about the reduction in travel by patients and doctors, between remote communities within Alaska. And then, of course, in kind of the searches and exploration of what Stewart was up to within the state of Alaska, I happened to come across Henrik's company, OpenTelehealth, that is doing similar things for the country of Denmark. So Henrik Ibsen is the CEO of OpenTelehealth. And Henrik, it's so wonderful to have you join us today.
Thank you. I'm just going to unmute now, and thank you for joining. And everybody, ladies and gentlemen, thank you for watching in. It's a pleasure to be here. I'm very thrilled to get this opportunity. So I'm just going to launch right into my presentation here. I'm just going to share my slides with you so you can see what I'm doing. And share my screen here. Here we go. So I'm so happy this is going on Zoom because I feel right at home. So I'm going to entertain you with some background story about what we're doing in Denmark, the business model we're working with internationally, and I will show you the system we're actually working with, so you can get an idea of how that works. So as an entry for this, I'll just tell you that what I'm about to tell you about this system is not something we want to do or have plans to do or have ambitions to doing. This is actually what we've been doing daily in full production for thousands of patients since February 2013. So this is an extremely mature platform. We have spent, I think, more than 30,000 hours by now in developing it. So it represents a substantial effort. It's a regulatory approved medical device class 2A in the EU. And it will be too in the North American as well. But we are okay to do anything in the US because in the way FDA is put together, we can actually put this on the market there. So, but it will be a medical device because that's what we want to do. We want to be a serious medical device. We cover all chronic diseases like COPD, heart failure, diabetes, and a lot of other stuff that isn't chronic diseases. But I will get back to this, and this is done by configuration. And we have try to make this a very systems within healthcare. I have seen that things that are not simple have a tendency to be very difficult to scale. It takes a tremendous effort to scale things that are complex, and it very easily becomes complex as soon as you finish doing the IT. Then you have the organizational change, which is 85% of the effort, which you probably know if you tried this. So we want to make something that is extremely simple because, like the iPod originally, it was easy to use. So it was one button so everybody could operate it. We have tried to copy that philosophy in making remote monitoring very accessible and simple, which goes for the clinician and for the patient as well. So this platform has been tried and true in Denmark. It's been gone through a clinical trial. 1,200 patients in a double-blind project used the platform for 12 months non-stop. And we had a full compliance. Nobody left the project, and everybody thought it was fantastically easy to use. So we sort of like hit the mark on the usability thing there, and we also showed that we have a positive economical effect on the society by using this, which incited the government to make a decision on using this platform to roll out in the entire nation of Denmark. And they did this because it originally was funded by the government. So this is now the official Danish platform for remote patient monitoring. It's going to be rolled out initially to 40,000 patients in Denmark, probably making Denmark the only nation, albeit a small one, that has decided to have one consolidated platform for remote monitoring, which is quite cool because it opens up a door to do lots of different stuff as well. So this is going to be nationwide by 2019 on COPD initially. And of course, what we've been doing is extremely mature as a platform. It's very high level maturity. So the technology readiness level is all the way at the top. It's a white label platform, so we basically provide it to people who know what to do with it, doctors, hospitals, IT organization, and who not, because we don't have the power to sort of bring it to the market where we want to go, and we want to go everywhere with this. So enabling and empowering organizations in the market that can take this into production, that's basically what we do. And the platform we have created is a very powerful empowerment platform for doctors and patients, and the team between the doctors and the patients, tying them together in a team that work together in unison to make the life of the patients better, instead of the patient being sort of like a passenger on the health train. They participate in the disease management, they know what they're doing, and they're putting an effort, and the doctor as well is empowered to do stuff that they normally usually can't do, but I'll get back to that. The part of the empowerment is showing the data from the patient to the patient. So all the monitor data that the doctor can see is enabled to be showed on the patient's tablet or smartphone as well, which enables the patient to follow his measurement and actually see when the blood pressure goes up or the blood saturation goes down, and inspire them to get out there and do some exercise and get more air in the lungs and generally improve their health. You would notice that we don't do any threshold indications on the measurements that are shown to the patient, and this is by purpose in order to avoid anxiety in the patients. That is unnecessary. They just need to know that they should do an effort, and the nurses in the back end take care of doing the advertising and the escalation if things get out of hand. And the patient know this and have a lot of comfort by knowing this, and they have a lot of high level of confidence in the system. Of course, we do video conferencing. We also do messaging internally. We do a lot of stuff in devices. We can support third-party device suppliers like TuneNet from Qualcomm, or we have our own Bluetooth implementation. But we basically support all kinds of devices for all kinds of data you can imagine. And quite a few you probably can imagine as well. So let's just go on to this. When we did this, we were charged with a job to make something that is simple, flexible, scalable, affordable, regulated, easy to use. All these impossible demands, but they gave us a very tiny budget and impossible little time to do it. So the only way to do it was to be very innovative. And we have done that now, and now we have a mature platform that we can put on the market for a total cost of something like a grande latte Starbucks cup of coffee per month, which makes it within the reach of just about anybody out there. So we are not putting it in the way of rollout. We are giving you any opportunity to go to scale with this instead of trying to suck out all the energy of the project by having high prices, because in my opinion, that's one of the things that have been killing projects all over the place. So projects dying all over the place are things that are dying from something I have termed pilotitis. And those of you who have done telemedicine or remote monitoring or whatever kind of mobile health you've done, you have seen pilotitis. I have seen that a lot. And when we started with this platform in 2011, we have also seen a lot of pilotitis. We've seen a lot of silos die, and we were analyzing this and sort of made some conclusions here that some of the things that kills projects are extremely high costs for licensed software. That will kill anything. It won't scale. Other things will kill you if you are based on proprietary hardware, because it does work well in a couple of hundred instances. But if you try to scale a box that can do everything to 500,000 patients, you are definitely not going to fly with that. It's going to be too complicated to maintain. One of the big killers in telemedicine and mobile health is when you do a dedicated system for a disease like diabetes. And there are tons of diabetes systems out there, as well as COPD and other kinds of systems for sleep apnea, diabetes, and God knows what. All of them have a common trait, and that is that they are not able to handle comorbidity patients. And everybody knows that nobody above 65 has just one diagnosis. We all have a lot of diagnoses, so everybody's comorbid. So what happens is when you go into the diabetes system and the patient develops hypertension or heart failure or any other kind of disease, the diabetes system fails because it is unable to handle the different diseases that are actually on the patient. So the patients have two different systems. I think not. The doctor should use 5 different systems. I think not either. I just came home from Brazil, where a very big hospital in Brazil called Albert Einstein told me they had 6,000 telemedicine patients, and they were very proud of this. And then I asked them, okay, so how many systems do you use? Okay, we use 50. Okay, is that a problem? Yes, it's a big problem. So this is also a pilotitis killer. If you cannot scale out in terms of handling different diseases, then you die as well. So in order to fix this, we did something else. We took a simple Android platform like this and made this the hub. So this can be bought anywhere, standard off-the-shelf device. And we took medical devices like that one. This is a Noning saturation meter, a BLE one. It can be bought anywhere. So you can buy these different devices and you can kit them together to fit to different disease groups. So this is like off the shelf. We don't do anything special. We just buy them, put them together in a kit and give them to the patient in a suitcase or whatever. And then we have one kit for COPD, we had one for heart failure, one for diabetes, even one for pregnancy, which is fortunately not a chronic disease, but it is a clinical condition that can be described in terms of what do we want to monitor on pregnancies, because they want to be monitored as well. And you know, whenever a woman becomes pregnant, fortunately she cares a lot about that, and instantly she wants to move in with the doctor, right? Bring him in the house and don't let him go before I have given birth to my child. This is common for everybody, but what they're really saying is, I would like someone to keep an eye on me. So why not monitor pregnancies? And we've done that in several projects in Denmark, both normal pregnancies and complicated pregnancies. And it gives a lot of comfort to the women that every day they can communicate with someone who knows stuff and look at the data, and something gets out of hand, you will be contacted by a guardian angel. And that gives a lot of comfort to everybody with a disease, a diagnosis, or a pregnancy. And you can have other diseases. It could be post-hip replacement operations if you have modeled to do something. And this is basically what we did. We have had 8 different clinical platforms, even 2 different COPDs and 2 different heart failure ones in Denmark for 4 years now. And, you know, there is a gold joke going around. Why do, this should illustrate, why do we have different configurations for the same disease? And the joke is like this. What is the difference between a supervising doctor and God? Well, the answer is that God knows he's not a supervising doctor. And this basically means that if you have 2 different doctors managing the same disease, they will have completely different opinions about how to do that management. So who am I to decide how to do it? No, I will give them a tool so they can configure their exact same personal management paradigm and implement it. And I just let them do it. So we adapt to whatever clinical situation we have. This is what we do. We try to move the doctors to the patient's home by having 3 parts in it. One is instructing the patients. Second is monitoring the data from the patients. And third is actually asking diagnostic questions for the patients. Why do we want to instruct the patients? Yes, we want to do that because a patient that has not been instructed to remain seated for 10 minutes cannot give you a blood pressure that is valid for anything other than concluding that the patient is alive. You need to know he's been resting, the pulse is resting. Otherwise, how can you conclude anything based on this measurement? So instruction is important. Health data measurements is important, but also the most important part is the diagnostic question and answers about the context and conditions of the patients. Do you cough? How much does you cough off? What color do you cough? Is it yellow? Is it green? Has it changed color? All this is important to know. So this we have put into the system as well. So basically we allow the doctor to create some kind of questionnaire that it contains this 3-part, push them out to the patient tablets along with their schedule, telling the patient exactly when to do this, and it pops up on the tablet with an alert, and the patient goes through the instructions, the question, and gives the answers and measures the data and all that. And when finished, they send it out to the cloud, and instantly it's available on the nurse's desk to review and intervene. So she intervenes if something is amiss. If she says nothing is bad, she just leaves it because then nothing is wrong. But if she intervenes, she can send the patient to the hospital, have a video conference, send a message, email, some kind of intervention where she takes responsibility for acting upon the data that has alerted her to intervene on your behalf. That's all we do. It's not an electronic health record. We don't do a lot of booking and medication and diagnosis and classification. None of that. We only do the specific monitoring the data streams, triggering interventions if it's necessary, and only when it's necessary. And that's what makes us scalable. So this is the heart of the matter. I made a very simple questionnaire for you. I'll get back to that in a minute. I'll just focus on the left-hand side where you can see the actual data types that can be modeled into the query. We can combine questions with actual measurements. So each node can be a measurement node. And the things we have supported by Bluetooth are the one on the top, which is automatic or manual, which means like things like blood pressure and weight and glucose in blood can be done by a Bluetooth device, or it can be entered manually. Of course, you cannot enter an ECG manually. That's like stream data. But the other ones, the simple ones, can be entered manually. The ones below, where you can recognize a lot from the pregnancies, are done manually and has to be input manually. But still, it's a data type that can be used for trending, thresholding, intervention, and so on and so forth. So that's one kind of intervention, that's data and thresholding. But on the right-hand side, if you look at the flow we had created here, and this is the doctor's tool. He's doing this with the graphical interaction design tool. It's on the screen. I'll show you later. And this one he's done like, welcome and sit down and relax and prepare to be monitored and wait for 15 minutes, in this case, 60 seconds. Prepare for measurement and prepare for additional diagnostic questions and so on and so forth. Excuse me. So the first he answers is the questions to the patient. Do you feel good? It's a very simple question. If the patient answers yes, we're done. He can go back to the fishing part. If he answers no, you will notice that in this we're branching out and doing something else entirely now. And while we're doing that, the branch is painted yellow, which means that there will be a yellow notification on the dashboard in the nurse's desk here because the patient wasn't happy. That means you need to intervene with this patient. Maybe something is wrong. So the doctor decided to paint this yellow because if the patient is not well, the doctor has decided that the patient should get attention from the nurse and put on top and on the top half from her to-do list. And immediately we go out and do a saturation measurement with pulse, one of these guys. And if that saturation measurement is, I'm just going to do one on my finger here. If that saturation measurement is too low, it means that your blood saturation is bad and mine is okay. And then you will trigger a yellow notification. If it's really bad, you will trigger a red notification, which is the alert level notification. And this will also go onto the dashboard as a notification to intervene because the doctor has decided that such a threshold should make an intervention take place. So this is also programming by the doctor, right? The last part is that if the patient is unable to actually mount this on the finger and perform the test and has to skip it for some reason, either because the device doesn't work or because the patient is really bad, then the doctor has decided to make a red intervention, a red notification on the dashboard here, because if you cannot mount the blood pressure and give him the data, then you must be really bad. So I need to see you, and I need the nurse to reach out and find out what's wrong with you. And then you can go on to ask more questions. Do you feel dizzy? And if yes, you will have more measurements and so on and so forth. But you will appreciate that this is actually an opportunity for the doctor to frame the programming of the knowledge he has about the specific disease of the patient. So, and if this patient group that is using this questionnaire for monitoring and daily or weekly follow-up, this has been programmed by the doctor. So he will do this only one time. And the initial phases of the project, he will weld it to the system, and it cannot be changed until the doctors come back. And while it's there, all the nurses are executing this on the patients, or the patients are actually executing themselves and giving the data to the nurse. But this is by programming from the doctor, which empowers the doctor to do exactly the data acquisition from each patient group that he wants. And the best part, he don't even have to call the consultant to do it. He can do it himself. So this is a very powerful empowerment of the clinicians to get the data they want in the way they want it, with the rules they want it, and how to act upon it. So this is one of the really, really big strengths we have in this kind of setup. Of course, there's a number of notifications on this to-do list, and you will see that all the ones that are green have been erased because they don't have to be there. We don't need to follow up on those. So 85 to 90% of all the measurements received from your patients are not relevant to look. You have to look on those that have given you cause for intervention. So that makes you available for, or it makes you able to handle a lot of patients. And the numbers we see now is that one nurse activating this portal for 3 hours a week can manage 150 patients. So if she does it for 40 hours a week, she can manage 2,000 patients, and that's one nurse. That's pretty cool. So the alerts here, you can see the notifications are red, they're yellow. The blue one signifies non-compliance. If the patient has been programmed to file a data set and respond to questions each day at 2 p.m. and the patient fails to do so within the allocated 2 hours, then we will get a blue bell signifying to the doctor or the nurse that this patient was non-compliant with whatever has been programmed, which is also valuable information in itself, obviously, because then you know they didn't take the pill or they didn't have the blood pressure ready, whatever. So this is also something we need to know as a clinician. The last two ones just indicate there is unread messages back and forth, and we have messaging inside the system as well. I will show you that. So comorbidity we handle by adding more questionnaires, more configurable diseases to the same tablet, to the same patient. This can be a smartphone, this can be a tablet, can be a PC, whatever. We can even support you using an SMS-based service where we actually take each of these boxes and map it to an SMS text message, so we can get the data from people who don't even have complicated or high technology telephone, but just a GSM smartphone, a GSM phone with basic SMS will still allow us to get these data, because we just pop them out as a text message with a question mark, and they return the data, and we sort of consolidate it into the same model, giving us the ability to get the system running for across all kinds of technology available by the patients or the clients, be it GSM phone, smartphone, tablets, whatever. Excuse me. So what we do is we monitor different kind of data streams from devices, from questionnaires, responses, we have scheduling events, we have the messaging, and we can do the video, and we can even in the future we will have devices from the hospital, so data from those, as well as Internet of Things like phone alerts, GPS alerts and stuff. But what we do in OpenTelehealth is we we monitor these data streams and we trigger notifications whenever they're outside of the parameters as programmed by the doctor. And that's it. That's what we do. So basically, we have this server. This is our business. It has open interfaces toward the EHR on the right-hand side and open interface toward the app on the left-hand side. So if you want to create your own app or somebody else has it, be my guests. You can put the data into the server and we can still be compliant. I'm not owning the app. I just make sure that there's a portal ready and an app ready so you can take this out, set it up, and go and start doing it. I had a client in Norway who signed the contract and put patients on implementing this system within 3 weeks. So it can be done pretty quickly. And this is a target in itself. We need to enable anybody to go live with this fast. And then if they want to change the app into something better or integrate to the EHR, they can do that after they have taken it into production. They don't have to wait for it, which is important part. It's completely cloud-based. It's very easy to set up and very easy for us to maintain. So we sort of like take care of that part. And all you have to have is an internet-enabled PC and some kind of device in the patient end. Maybe some medical devices would be good as well. But many people have a blood pressure meter and a bathroom weight in their home. So this would actually enable you to monitor a lot of people with hypertension and maybe even heart failure. So we consolidate things in the data warehouse. If you have multiple instances all across Alaska, for instance, you can consolidate in the one data warehouse. All the data is yours, not mine, your data, which enable you to have a single point of integration. And that's enabled you to feed it into your national EHR or whatever kind of national system you have. And it also, after some years, enabled you to do some very interesting big data research and prognostic or predictive analysis on people's diseases based on historical data. So that's also something that will be important in the future, but that's from a couple of years from now. So moving into our business model, we are putting this on the international market. We are putting in all kinds of places in the world. That's the plan at least, and we already present quite a number of places, as you can see. I just returned to Brazil, and it was a very, very good place, and there's a lot of business there. I also had a flu, and I'm struggling a bit with that, as you can hear, and I pardon that. But this is basically what we do, and this is the logistics we have. Oh, there's something wrong with this one. But anyway, ignore the one in the middle. The logistics, the platform here is basically the things in green is the things that we supply on the cloud. We do the hosting, we do basic consultant add-on development, but that's all we do. Our partners, our business partners in the market, and we have an example in Canada where we're partnering with St. Elizabeth, which is a big healthcare company. They do all the things in the middle, like logistics, device subscription, and local consulting, and sales and marketing. And that name, I got to find out why that name is there. I really wonder about that. Sorry about that. Anyway, as you can see, we also need to have someone setting up a healthcare call center and doing configuration consulting and bringing the stuff out to the patients and following up on that. But that all takes place in the local market because as a technology provider, we have a business-to-business setup. We cannot help anyone do that. So I think from my point of view, we are probably one of the very few companies that does a complete white label business-to-business remote monitoring solution, because everybody else I've seen are bringing to the market themselves under their own brand and try to sort of like claim the entire business and roll that up. We don't, and I think we don't do that because we haven't got the necessary muscle to do it. But I also kind of like the way of enabling other people to do whatever they want to do, develop their own apps and bring it to the market like they want to, and then take care of the complicated part, which is the regulatory and the remote monitoring part in the back end, which we have taken care of. And of course, since we have a very small footprint, we can integrate to all kinds of systems out there. So looking at the market, it's very popular to have a complete Bluetooth-based kit with all kinds of medical devices and tablets and stuff, which is for the severe patients. But you will probably also know, if you tried this, then the logistics of supplying all the patients with the Bluetooth kit is very complicated. It can take a lot of time and can be very difficult. So actually, it's a challenge to have only Bluetooth-based kits. So we are trying to do that in a way that we have Bluetooth kits for the severe patients or for the rich patients, but not for every patient because it's expensive. It's 85% of the cost in any monitoring project is the devices. And the logistics and maintenance is a big trouble, because if you need to cover a big area geographically, you need to have someone be able to go there and fix it. So I believe that the biggest scalability lies in the middle, where you have a combination of smartphones and bring-on devices that can be or not Bluetooth, which is probably going to be the majority of the patients in the US, in Canada, in right now and in a few years. But it will be a combination and will be based largely on people having smartphones. But Right now, in the majority of the world, we know SMS works. So even if people have very basic medical devices and an SMS-based phone, we will still be able to roll this platform out and get the data from them, because most people with diabetes, they have a glucometer, and it's not a Bluetooth one, it's a manual one. So what they need to do is submit the glucose level one time a day. They can use that SMS feature to do that. And even it's very simple, it's very easy for them to do it, and they will have someone in the back end, they will have the guardian angel on the shoulder looking over the level of the shoulder on the glucose level, and actually reacting to it and reaching out to the patients on their SMS and saying, hey, Fred, you need to do something because your glucose level is completely way off. Please have such and such attention on that, and take care of your diet. We can do that when you get the data. So we have to get the data, and we cannot be picky about how we get it. So I'm happy with SMS. If it gets me the data, that's good, because my basic platform is based on getting data to make interventions. So we should not exclude anyone, especially not SMS. And actually in India, you would wonder to know that 750 million people there has an SMS-based telephone, even though only 500 million of those people have access to power. So SMS is still a powerful thing out there. That's the slides for you right now. I'm going to just go right into my portal here and show you how this is actually done. As you can see here, I have pre-coded something, and I have a start. I have a question of feeling well, and if the answer is yes, I'm going directly to the weight here. And if they answer no, I will take a blood pressure measurement, and they fail that, I will give a yellow alert here. And doing the weight, I'll do the threshold measurement, and if the threshold is higher than the red high, I will have an instruction to the patient here: drop the cookies. If the weight is a bit high, I will say eat less cookies. If the weight is normal, I will say don't change the cookie intake. I have something wrong with that arrow. No mind. If it's too low, I will tell them to eat more cookies, and if it's really, really low, I'll tell them don't stop eating cookies, my friend, because you really need it. And if they don't have the weights and they want to skip it, then I'll just ask them how many cookies do you actually take. So this is the programming I've done. And then what I do is I save it, I close it, and then I publish it to my patient account. And then when the patient logs in, what the patient see here is this is simulating a tablet. So the letter and the sizing and stuff can be off, but it's because it runs on a browser, so don't mind that. If you run it on a tablet, it looks completely different. Logging in, you get a very simple menu. You can, of course, change the password. The calendar is for video booking, so you can see if you have any video consultations. Information guidance is external links to YouTube's videos for instruction of how to put on pressure cuffs and stuff like that. My results is actually my measurements shown in a graph, so I can follow my developments in my blood pressure and see here's a drop. That's probably because something was wrong there. But this is a very important part of the empowerment for the patient, right? So going back in the menu, I can see whenever the doctor has actually seen my data and reviewed it, I will get a receipt from the patient or a receipt from the doctor. So I'm just going to show you how to do that. It is sort of like just sidetracking for a minute. So what I'm doing here, I'm going into Lisa here, and I can see that Lisa has 182 unacknowledged questionnaires, which is not normal, but this is sort of like a test platform, so that is to be expected. So I'm sort of loading that. It will probably take a lot of time, but these are mostly green, so they would be just like removed in one workflow here. I'm just going to do that. So now she has none. Okay, so I can go into Lisa again, and I can see that okay, there is it's been acknowledged here, and now I wonder how the review looks. Oh, see all the receipts you got from all the reviews. So every time you actually acknowledge a piece of data, then you acknowledge the responsibility for the intervention, and that responsibility has been communicated to the patient so they can rest easy, right? So the messaging is going back and forth between the clinician and themselves. It's completely tracked inside, and it looks like SMS, but it's similar, but it is inside the system. But the actual key to the measurement here is, as a patient, you have different ways of reporting your disease, and this is just some example, but you can recognize the one, how are you feeling? Are you feeling well today? Yes, I'm actually okay. So let's enter your weight, and I'm going to be really heavy today, and this is 130 kilos. So drop the cookies. Fair enough. I got my feedback. I will submit that reply, and it's gone into the system. And next day here in the overview, you can see I have a red notification, and it's actually from the result from the how are you feeling. And if I sort of like look at that, I can see, oh, look how the weight went up. Okay, so I can sort of I can send them a receipt for that, and I can shut it down again. And Lisa now has immediately received the receipt from the doctor here, acknowledging that. But you know, the doctor is sort of like, nah, this is not for real. There's something is amiss here because that's way off target. So I'm just going to go in here and just going to deselect this weight because I don't think it's real. I think they pranked me, so I'm going to ignore it. And I'm going to going back to that. And when I go into Lisa's curve here to check her trending curve, I can see that the 130 kilos, if I have them somewhere here, they have been removed. It's not there anymore. So what is left is the one that I thrust in, which I want to be trended. And you can see all the curves for Lisa that has been put in here are actually shown on the screen. So that's kind of the way it works. If I go back to the questionnaire a bit, because I think that's quite exciting. I can create a completely new one based on the one I have, or I can make one which is completely empty. I'm just going to show you how fast this works. So I'm just going to start. Let's have a start and have an end. I have a welcome. And create, and connecting the dots like that. And then I have the first diagnostic questions here. Are you feeling well? I'm going to do that a yes or no, and I'm going to use that for branching. So now I'm going to branch. Are you feeling well? Yes, I feel well. I finish immediately. No, I don't feel well. Okay. Let's see. We could go into multiple choice here. And I could create a questionnaire that is based, a questionnaire element that is based on a multiple choice where I can sort of like sum together the answers. I can add intervals. So now I can, if I branch on this interval, I will have a red alert. If I branch on this one, it will be yellow. If I branch on this one, it will be green. Or I can have more and give specialized feedback to the client, also the patient. But all of this was based on adding together the results of a multiple questionnaire entity, sort of to evaluate the patients, how they're doing on the different number of different parameters. And then according to how they're doing, I will score them in my intervals here. And they will be tagged as with a notification alert level, and they will also receive an appropriate message from the conclusion of this note. And this takes a bit of time, so I'm just going to do that. I'm just going to take a simple measurement here, and you can see here from the measurement types, the one we have, I can put in a respiratory rate like that. And I need to make it manual because I don't have a Bluetooth device for this. And if I add this, it will branch on each threshold specifically like I showed you in the weight. And I'm just going to do that. I'm going to do here, going to do resp rate. Normally you put more text in this and also do a lot of coaching information to the patient because they need to be told what's happening. But this is just going to be very speedy, so I'm going to spend time on that. So here you see I connect this one, and now I can actually add arrows here from this one to what happens if they skip it, what happens if the respiratory rate is too low, what happens if it's low but not too low, what about if it's normal, what happens if it's high, red high, and I can group this to different notifications. Notice. Excuse me. Oh, where did that go? I probably deleted it. I'm just going to do it again. And then I can connect here, the red one to that, the red, yellow one. I'm going to connect that as well. Oh, if I can catch it. So this is the basic idea of how you do stuff. You program the way you want to interact with the patient, and you do this as a doctor. You take responsibility for the way you collect the data, and you know exactly what you're going to get, when you're going to get it, how you're going to get it, which means that you can make this programming once and for all for any kind of disease group you want to manage. Give it to nurses, and one nurse will be able to handle 2,000 patients, and you can go back and play golf. This is like the doctor's dream. So as you can see, this is extremely powerful empowerment of the doctor as well as the patients, in the way that they are able to see, the doctor is able to follow the patients exactly the way they want it. They can assign different monitoring schemes to different patient groups, and all patient groups are actually separated. So if you have heart patients and you're logged in as a nurse, you will only see the ones that are heart patients. You will never see anyone else. So you don't get to see patients that are not in your care. You get to see patients that are in your care and no one else, which means you can have a lot of different clinical teams working on different patient groups with different diagnoses within the same system. You don't have to branch out. So it's a kind of, it's in Denmark, it's by laws, you need to separate the people in the team. So you only get, you can only be seen by people who have a relevant course to see your data, not anyone else. And as you can see here, we have the flyover help. This means that even when the doctors log in and haven't read the manual for a couple of days, they can still see what goes on. And they say, okay, there's 200 messages from the patient. I had to check. Oh, I better mark this as red. Right, I'll do that. So, okay, that's good. I'll go back. And now the red arrow has disappeared. It's still yellow. I'm going to fix that. So I'm just going to, oh, there's 3 unacknowledged. I'm just going to remove that one. Acknowledge, right, and then I'll go back and update. So that's basically what you do. And when you have removed everything, the actual line here is removed from the to-do list entirely, and the nurse is finished with her job today, and she can start again tomorrow. This is not a system that is monitoring people with acute systems. This is not an acute care platform. This is monitoring development of conditions in order to do interventions. And we have already seen a lot of COPD patients saving trips again and again to the hospital because they get feedback from the automated algorithm built by the doctor. And so when they go into an exacerbation in COPD, they catch it before it goes into pneumonia, and they can start a penicillin cure before they go to the hospital, which means that the number of doctor visits go up and the visits to the hospitals go down, and the net effect is that we all make money. This is a big issue because in many hospitals, they get paid for seeing patients, not by keeping them away from the hospital. And that's a big issue. You got to change that to have the positive economic effect of a system like this. But we still see that as a big challenge in many, many societies all around the world. But some, and especially in the US, have tried moving into rewarding hospitals and healthcare organizations for actually keeping people healthy. And this is where we come in. This is what we do. But we only do this part. And we aim to do it extremely efficiently. So when you create a patient group, you set a threshold for the patient group, and of course this will be the one that everybody inherits when they are assigned to this patient group, and you can be assigned to different patient groups. And yeah, we have actually the system running in Chinese as well. So when you add a patient to the patient group, you will see that they inherit the basic thresholding for that, and then of course, you can go in and edit the specific thresholds for each specific patients to the exact level you want. And like this one, for instance, is really off. So the respiratory flow here is definitely not going to be this one. It's going to be something more like, it's going to be peak flow. So I'm going to say like 350, 250 would be reasonable limits here. So I can update that and add that to the patients here. So you can actually do specific patient-specific setup. You can do a video call. We have a possibility to upload the prescription if you have a picture of that. But you can see here, this is very, very basic, the messages we have here. And if you go into the administrator mode, you can also see that we, of course, have user roles and patient groups, and we have the users as well, which can be pushed in from external system or created inside the system itself. We have an audit log, which means that you know everything about whatever anybody does in the system. It is completely logged. And we even copy this to an external log outside of the server. So we have a double log. So if you sort of like blow it up, we still have it. But I think you have probably seen the most essential part of what we do. And the funny part is there's actually no more to it than that. It's so simple that I can sort of like train and implement the system over in the course of one day. So if you know what you're doing and you already have your clinical protocols ready, you can either sort of usurp the ones we have already in Denmark or in Canada, whatever, or you can make your own in a couple of days and start moving this into position and start monitoring people and actually doing good. And since you can do this one, use this one on every platform out there that has internet accessibility or SMS, it's really easy. If you want to use Bluetooth devices, you need to have an Android platform. That's inescapable. But otherwise, if you have manual input, like I just showed you, you can do this on every single device you can imagine out there. All right, I promised Ted I'll do this in 40 minutes, so that's now. So I will just open for questions. Go right ahead. Should I stop my share here? Or I'll just keep it on for now if some questions. But yeah, questions, anyone?
Well, I guess I'll open it up, and just so that people know, if you hover your cursor at the bottom of the screen and find the Q&A function, you can post questions that way. But while people are doing that, Henrik, I guess what I'd like to chat with you a little bit about is, I think first off, people will probably want to know, like, it seems like your system, you had mentioned that the country of Denmark is taking a look at the implementation or the use of this approach in 2019. Is that correct?
No, that's when we go to the huge rollout. We've been doing this in Denmark for thousands of patients since 2013. So this is a 4-year mature platform with thousands of patients in it. We have tons of data, and because of this, the government has decided to go really big and implement it as a general system, standard system in the entire country for chronic disease people. Yeah. We also use it for pregnancies, complicated pregnancies, simple pregnancies, and it's going to be used for a lot of different stuff: psychology, psychiatry evaluation, tracking growth of children, and all kinds of stuff. Because you just set up the programming, then you go right ahead. You don't even have to call me; you just do it. We're going to see it. We see a lot of bandwidth on that.
And other implementations of your system. Are other governments besides Denmark taking a look at the use of your system?
Well, governments, no. Yeah, well, that's not true entirely. They actually, you can looking at it in both Sweden and Norway from a government point of view. They do that, but they haven't concluded they want to go this way yet as an entire nation. And they will probably decide to have this as a part of the solution because it's a dedicated component that does this. So they need to have more stuff. So it won't be like all alone. It will be a part of a different setup, which is also what's going to happen in Denmark. But the monitoring part will largely in Denmark be by this. But we have companies a company in Canada called St. Elizabeth that I told you about, which has 8,500 employees, which is a very big company that does healthcare. Mm-hmm. And they have sort of taken the approach of using this platform to be more efficient in the way that they go to the market in Canada, which means they're now extremely more efficient in monitoring and bringing people away from the hospital than they were before, which means they can go to the hospitals and offer them a very, very good price on the service of bringing people earlier away from the hospital and clearing up space in the hospital because people go home earlier. So they reduce the number of days in the hospital. And that's what they sell. They don't tell the hospital that we have this fantastic platform that allows us to do such and such. No. That's not interesting. They use this as intended as a tool, a very focused tool, to provide healthcare in a more efficient way than they did before. And that's the key to the success.
Well, I think you mentioned at kind of a root philosophy that really it's a shift to a preventative approach to help people keep healthy and not have to visit the doctor or the hospital with a preventative philosophy versus...
Sorry, continue.
Well, I think that's kind of at the root. Like, I mean, there's some discussion within Alberta right now as a reduction in health costs with a shift from coal-powered electricity generation to non-coal, and that there would be a reduction in health costs because of the chronic disease, lung disease.
Definitely, yeah, I believe so. That's going to be big impact.
So this is using the same sort of preventative philosophy of helping doctors and nurses be able to help monitor more patients. So it's a different way of doing things, right?
It's a tool that makes you more productive, and it makes you commit your resources where they are needed, because we don't want to prevent people from seeing the doctor. What we want to make sure is that it's the right people who sees the doctor. So when you have the to-do list on your screen as a nurse, you know, okay, who needs to see the doctor? In my screen now, I know Linda definitely needs to see a doctor and John Doe doesn't, because that's what the system tells me, which means if I monitor 2,000 people as a nurse, what I do, the value that I bring is the knowledge that the patients that I forward to the doctor are the ones that really need it. Mm-hmm. Before, in chronic disease management, it's like this. If you have COPD patients in care, what will happen when they go to the two times a year checkup is that the ones that go to the checkup are the ones that don't need it because they're actually able to go. The ones that are unable to go, who need the checkup, doesn't go because they can't. So now, because we're monitoring them, they pop up on the screen and the nurse knows, okay, Linda's got to go. And she makes sure that she goes to the doctor, and you can see that the other guy that doesn't need to go, like Erna or Lisa, they can stay at home. So this is also a way of using your resources efficiently. So we don't want to keep people away from the hospitals. Actually, what we want to do is to make sure that the right one goes, and you don't stay there more than you have to, and that you can be careful in your home as well. So I think basically the philosophy is right. That you have it right there. It's just a little twist on it.
Mm-hmm. Now, it also seemed to be sort of predicated on a way of sharing patient health records. That's built into the system. Is that correct?
Well, except that we don't have health records. We have the monitoring data. The basic data we have on each patient here is actually most installations we have. These data comes from the health record system, like we talked with earlier with Stewart. He said that they have electronic health record implementation, and they actually, this is where they have the key data, the host data, the master database. And that means that we actually take the data from the master database and pushes it into our system, and then we use that reference to put our monitoring data on top of that. So the record is in the external system. What we have here is we have the measurements, we have the monitoring data, we have all the data that has ever been monitored on Linda here, which is not a lot. If I take let's take Lisa instead. We have the data of the monitoring of the measurements, and that's what we have. We also have all the knowledge about whatever questions they answered. If they have, that did her again. If you take Lisa and look at the questionnaire, we have the questions that has been posted, the answers to the questions, and whether or not they actually triggered an intervention alert, intervention notification. That's what we have. That's the only thing we have. We don't have the electronic medical record, the medication history, or we cannot check the medication interactions or book them for a consultation. What we do is we have a look at the data, and if someone needs to do something, we make sure the patient goes to the doctor, and then it's out of our hands. It goes into the electronic medical record, and someone else take care of it. That's not me. All I have to do is to raise the flag and make sure someone goes that needs to go. That's my job, and now don't do anyone else. And this is the beauty of it, because it's so simple, the job, and it is so important that if I do that well, I don't have to do anything else, because then I have made sure that if 2,000 people are monitored, the ones who need to go will go.
So in a way, you're empowering the health professionals to be able to provide different types of preventative health services to the patient.
Yeah, that's true. That's true.
So an individual doctor or nurse would sort of sign up into this system, and then they would have a secure access, and the patient would be able to use their devices, which kind of surprised me with the kind of open compatibility you've built into the system, particularly with lower price SMS phones, which I didn't expect that there would be compatibility with.
No, but it's really easy, because if you look at the questionnaire and the way it is built, this is like a process flow, and you probably noticed going through the questionnaire on the client here, that once you start the visit, what you see here, and you saw the questionnaire in the design process, it looked complicated, right? But here you get one screen at a time. It's one question at a time, and you answer that. So it's really uncomplicated, and this is why when we used it on the clinical trial in Denmark, and the average age of the patient was like 70, and whether you have patients from 40 to 99, they could operate this because it was like one question at the time. Who can be confused about that? Nobody. But also, if you sort of like break it down, say, okay, this might as well have been an SMS text on a basic phone, and then you can just right? Yes or no, if you want answer or just Y or N. So it can be easily mapped to a simple device as in a mobile phone. Of course, I can't do ECGs on that, but getting the glucose level, getting the blood pressure, getting the respiratory rate or the saturation measurement can be done easily. Yes. So it's an empowerment tool of the doctors to support the doctor programming. So whenever the doctor has done the programming here, he doesn't have to think about if this is done by a smartphone or a tablet or a web browser or a whatever. That's not his problem. He has to care about how to construct the clinical result and the clinical process of asking questions and getting results, and how to react to that and how to program it. And then it will be implemented in whatever devices is available, and the data he gets will be valid and will be processed according to the algorithm he has constructed, and the results will be prioritization of people's data, and the nurses will not really know what kind of data they have if it comes from a smartphone or from a GSM device. They just know they need to intervene because it's out of bounds, right?
Yeah. So just to let our webinar audience know, how do the clinicians sort of connect into your system? Like, how do they access it?
Well, they access it through their laptop wherever they are in the world. It's completely cloud-based internet, so the doctor can be anywhere. You can source the doctor to a expert in lung diseases in Bangladesh, or you can, as a nurse, source it to a healthcare institution in Hawaii who will look at the data on a daily basis and intervene. You don't have to have a geographical connection between your patients and the one monitoring you, because it's all in the internet. As a nurse or doctor, all you need is a browser. What I've shown you is on a Chrome browser. It can be anyone else, Firefox, Microsoft, whatever. And the patients only need to have access to the internet to be able to run this one and actually submit data.
And in terms of security, is there encryption built in, or how is security?
Security has been vetted extremely, and if you look at the chain, there's sort of like two different levels of it. There is a data in flight and data at rest. Data in flight is encrypted from the Bluetooth device to the tablet using Bluetooth encryption. From the tablet to the server is used the web encryption, like HTTPS, encrypted HTTPS. From the server to the database, it is encrypted because there's encrypted connections inside the Amazon hosts or the cloud-based. And in the database, the base is encrypted as well. And if you really want to go overboard, you will set up the system with an external database with encrypted usernames and passwords and personal health information and personal information on an external database, and we'll just use an ID in our platform to identify the patients. So we don't even know who the patient is or who they live, but we can get that data externally from an external source. We don't need to know where they live in order to do monitoring of them. So this can be completely externalized from our installation. This is a more complicated setup, and it requires more abilities in the client organization, but we support all kinds of security setups in this way.
Well, and of course, your business model, to sort of have a global model, you've had to go through all of the different jurisdictions, HIPAA compliant and all of those things. Yeah,
exactly. Actually, we're saved a bit by the regulatory process, because gaining a CE mark class 2A requires you to have very extensive ISO certifications, and the quality management system has to be audited from external parts by an institution that can give you sort of like the rubber stamp. And that the process of building that quality management actually forces you to go through a lot of stuff that gives you a very, very mature approach on how you manage data and how you change the data and how you provision data. So I think we have probably the most mature setup in terms of automation, traceability, and auditability that I have seen so far. This is the advantage of being new. You get to build it on the right tools.
Absolutely. Now, just I'll make one more ask of our webinar audience for questions. Give them a few moments to consider, and then what I would offer to you, Henrik, is a closing statement opportunity.
Right. So, should I wait for that?
Yeah, just a few moments, and then we'll check to see that Stewart is queued up for our next presentation.
Right, he is.
Well, I guess, Henrik, if you want to go forward with some closing statements for your presentation.
Thank you. I'll do that. I think the most important parts of what I do is trying to make everybody anywhere able to set up a remote monitoring operation without being knocked down by operational costs of software, license fees, and all kinds of project killers that you usually see. So the purpose of what we're doing is to get a high volume of people covered by remote monitoring, because this is the way we think we need to provision healthcare in most of the world. I want this platform to be able to monitor people on the coast of India where they haven't seen a doctor for years. I want to be able to build prefab hospitals with container boxes where you set up beds and you can have highly specialized equipment for monitoring pregnancies available in such containers, and the doctor can be thousands of miles away and look at the data in real time and tell the nurse or the patient in charge to send this and this lady to the hospital, which is 400 miles away, because if they don't do it, they will die in the childbirth. This is what we have within our reach if we remove the price tag on even complicated stuff like this and go for the volume instead. And I think instead of being greedy as technology provider, you should go for the volume. And I think this is a lesson that has to be learned by a lot of companies out there, because the prices are simply too high to go to volume. And we would rather have a significant impact on healthcare internationally and get the volume, because that's what we need to do. And I think if you have a humble approach to this, it shows anywhere that if you get the volume, you will also get the money. So why not take that approach from the start and say, okay, let's see if we can make some big changes in the way healthcare provisions in the developing countries. But even in countries that have been developed, like the US and Denmark even, which is a small country, we need this technology because we haven't got the hospitals to take care of our chronic disease people. Chronic diseases are eating 80 to 90% of our complete budget for healthcare. And if we don't do something intelligent about it soon and take that away from the equation, there won't be space for the one who need a kidney transplant. They will die because we have to spend money on the diabetes and they're occupying the hospitals all the time.
Well, I think that's a wonderful point to close on, Henrik, because I mean, healthcare costs. Every country in the world is faced with the same sort of scenario of healthcare and the escalation of costs, and how do you kind of help citizens keep healthy.
Yeah, that's really important. I think one aspect of this, which is also important, is that try not to do everything yourself. Try to incorporate open interfaces, because you will cooperate with other people, with other technology. And if you don't prepare for that, you're going to die. It's simple as that. One example is that we are actually now taking another national platform in Denmark for diabetic wound care and adding that to our platform as an add-on externally, and putting that into the package so everybody who has this platform will benefit from whoever develops new technology. So if Canada or other people develop new components and add it to the platform as their product, I will just distribute it without any cost to whoever else want to have it, which also make this a distribution platform for more intelligent modules that other people can do that I can't. But I will help distribute it because I have this open platform with open interfaces to add like kidney management or whatever kind of this specific disease you want to add. I want to be able to help adding new stuff. So if someone makes a brilliant app, I can add that as well and bring it out to the clients that I have already. So I want to make this in a platform that is supporting innovation and make it easier for even small companies with a good idea to get an international distribution just by adding it to this very simple platform. So it's not just remote monitoring, it's also big data and it's also innovation. And I'm really happy to be doing this. And I hope, I hope you have liked what I've seen so far. And if you want to benefit from this, well, I should be easy to find. And thank you, Ted, for the opportunity for this. It's been great.
Well, excellent, Henrik. Thanks so much for joining us.
My pleasure.
Wonderful. I guess what I'd like to do now is introduce Stewart Ferguson, who's with the Alaska Native Tribal Health Consortium, and he works on a statewide approach to telehealth within Alaska. And it was interesting because when I originally kind of did Googled telehealth and took a look at what different providers were we're doing, with the whole idea of looking at how potentially disruptive technologies or different approaches, innovative approaches could help to reduce carbon footprint. What I saw in Stewart's original presentation was the idea of telehealth kind of reducing travel of either the doctor to the patient or the patient to the doctor. And when you're looking at a lot of rural and remote communities, like we have here in Alberta and Canada, and that you have in Alaska, Stewart, that's a big challenge.
It certainly is, Ted. And, thanks for the opportunity to talk to folks today. Should I take it off from here?
Absolutely.
Great. Okay. Just checking. Can you see the first slide there, Ted? Okay. So, Ted, are you able to see the slides? Just checking. Okay. Good. Well, good morning or good afternoon to everybody in Canada. It's wonderful to have this opportunity to speak to our near neighbors to the east. I am based in Anchorage, Alaska, and it's interesting, you know, when I think about Alberta as a province and Alaska as a state, we probably have more in common than differences. We're both fairly large areas. Just to give you a comparison, Alberta at 250,000 square miles is about the third the size of Alaska. Alaska is close to 700,000 square miles. But that, you know, we both face large distances between our population centers. We both live in, I think, some of the most beautiful places in the world. We both have these mountains that are near population centers. And we both, you know, are challenged with delivering healthcare to some of these remote areas. So this gives you an idea of what Alaska looks like from my perspective. This is the mountains literally outside the city of Anchorage. Anchorage is just there at the back of this view. So our mountains come right down to the edge of the city. This is just going around the edge of Anchorage, just going down an area called Turnagain Arm. It gives you an idea of just how beautiful these ridges and high tundra areas are in our state. And of course, we're in winter, as I'm guessing you are too. And so this is what our mountains look like at this time of year. They're still beautiful places to go and to hike. And if you're an Alaskan, you get the opportunity to hunt and fish in those areas as well. It's an interesting time, I think, for both probably Alberta and definitely for Alaska, where our economies are somewhat dependent or heavily dependent on oil. And with oil prices being low, we are facing challenges in Alaska with how do we continue to provide and pay for healthcare. And it's becoming more of an urgent issue. And as a result, we look to telehealth as being one of the key strategies we want to use to not only decrease the cost of healthcare, but improve the quality of healthcare. Well, let me start with kind of a very basic question. What is telemedicine? Let's just make sure we kind of all understand what this is about. The formal definition that comes from the American Telemedicine Association is it's the use of medical information exchange from one site to another via electronic communications to improve a patient's clinical health status. Now, we oftentimes hear the word telemedicine, we hear the words telehealth. I think some years ago, there was really a difference between those. Telehealth encompassed more than just telemedicine, but the American Telemedicine Association will treat those as really synonyms, and I'll use that concept as I go forward. I would say going back before we had telehealth, we had this kind of unusual situation where our patients were more portable than their data. And if we wanted to send a patient from a village to a regional hospital or into Anchorage, the patient would arrive oftentimes before their data arrived, or the data may never arrive. And so we would move patients, but not their data. We have started to move into a world with telehealth and now with electronic health records where we can make the data more portable than the patient, which sounds kind of ludicrous. And years from now, we may laugh at this concept, but you know, it's really key to understanding the fact that with telehealth, when you can move patient data, that's the key to be able to treat a patient, to diagnose a patient, or to plan a care treatment for a patient without necessarily having to send the patient. There are different kinds of telemedicine. These are three kind of fairly broad areas. We just were listening to Henrik talk about taking care of patients through monitoring, and that's the one that I'm showing at the bottom, home telehealth, remote patient monitoring. It has different names, but that's the ability to take care of chronically ill patients, diabetic patients, congestive heart failure, chronic obstructive pulmonary disease patients, but to manage those chronically ill patients in their home, that's definitely a method for reducing the cost of care for those patients. At the top, a more common form of telemedicine, especially in what we call the lower 48, the mainland United States, is to use video conferencing, synchronous telemedicine, where you have live audio and video, basically what we're doing here today in this presentation. And then, of course, what we call store and forward, or asynchronous telemedicine, where we capture data and send it to a provider that can look at it at their free time. This is similar to an email concept and actually would apply to people that are watching the tape delay version of this presentation. So I will be talking today about some of the impact we've seen in the Alaska Tribal Health System. I work for the Alaska Native Tribal Health Consortium, which is really a consortium of 229 federally recognized tribes throughout the state of Alaska. The mission of my corporation is that Alaska Natives will be the healthiest people in the world. And we work as one organization with about 30 other tribal health organizations to deliver care throughout the entire state of Alaska. So I work here on the campus of the Alaska Native Medical Center, which is really, it's a tertiary care facility. It's a level 2 trauma center. It's the largest Native hospital in the United States. And we provide care to every Alaska Native throughout the state of Alaska. There are 6 regional hospitals that we work with. They're all critical access hospitals throughout the state. And then there are some multi-physician health centers and what we call sub-regional mid-level care centers that may be staffed by a nurse or a physician assistant or a nurse practitioner, and occasionally by a family physician. And then we have the dominant number of facilities, 180 small primary care centers or village clinics that are staffed by community health aides or community health aid practitioners, who are most often folks that are hired in the village. They receive about 4 months of training over a number of years, and they provide all the care that happens in that village, which is a real challenging situation when you consider that we have the highest rate of trauma in the United States. We have high rates of a number of different diseases, including cancer, and the health aides try to provide all the care in those communities. So this is where telehealth starts to make a lot of sense, because it empowers the health aides to work more closely with family physicians at the regional hospitals and with specialists here at the Alaska Native Medical Center. So when we started our telehealth system, we took a slightly different approach than most telehealth programs. Rather than focusing primarily on specialty care, we focus mostly on primary care. Our primary care needs are huge throughout the state. We have a lot of ear disease, heart disease, respiratory issues, and so forth. So we designed a technology that we could put, that was a ubiquitous, similar technology into every clinic, every hospital, that would allow us to focus on capturing data related to primary care issues and sending that information to family physicians and or on to specialists. To date, about 75% of our telehealth is primary care, and about 25% of our care is specialty care or consults coming in to Anchorage. This was huge for us when we designed this. We were designing a program for the state of Alaska, for the federal partners in Alaska, so the tribal health system, but also the veterans, the Army, the Air Force, the U.S. Coast Guard, and our public health nursing department. So we basically designed this to involve all of our partners in this, and they participated on 5 different committees over a period of 4 years, clinical training and other committees. We had a core project office that developed the technology, developed the programs, training materials, etc. And then we had 2 boards that would supervise this project. But over a period of 4 years, we built a system that was deployed to 250 sites throughout the state of Alaska. And it first went active in 2001, and this is 2016, and we continue to use the system. One of the keys for us was designing a user interface so that the users could very easily use our system with very minimal training and make it very intuitive. So we relied on touch screens on all of our systems. We created large buttons. We used green buttons, which were typically the ones that would use the most. The blue buttons they used a little bit less. The gold was to go into archives, and the red was to kind of log out or go to an area that maybe they may not want to go. We designed touchscreen interfaces at the village level and on our system where there was hardware, and we of course have a web-based interface for consultants and providers that actually have to review the cases. We have a mobile solution now where people can review cases and actually even create cases on iPhones or Android-based mobile phones or iPads. And we have an integration, a certain level of integration with electronic health records. Excuse me. So to give you an idea of how the system is being used, these are the projected numbers for 2016. Of course, we're getting close to the end of the year. We project we'll do about 43,000 cases this year. We'll have over 1,000 providers that use the system, and we'll probably serve about 29 to 30,000 patients. And since the beginning of this project, we've done almost 1/3 telehealth cases, worked with over 4,000 providers, and served over 100,000 patients. In the Alaska Tribal Health System, we have 153,000 Alaska Natives. So basically, about 2/3 of our entire population has been involved in telehealth since the beginning. And on a regular basis, we serve about 20% of the entire population through telehealth each year. So that is our store and forward system, and we've been using it, and it's been highly effective. As part of building out that store and forward system, we also had to build out a network to connect all of our sites, because when we started this project, we literally didn't have connectivity to some of the remote sites and even to some of the hospitals. So we built out a wide area network that now covers the state. It's been running for about 15 years as well. And in the last several years, we've actually been able to layer on video conferencing technology, because our bandwidth now is at the point where it's reliable, sustainable, and broad enough that it supports good video. We've relied on Video as our provider for that, and we have distributed routers, bridges, and equipment throughout the state. And this kind of shows where we have built out bridges and routers as part of that system. The system is been getting used more and more every year. To give you an idea, in 2016, in the fiscal year 2016, which ended September 30th, we had about 1.25 million minutes, so about 21,000 hours. Or in other words, the system's being used about 83 hours per workday. And that's by all of our partners, so they're using it for their purposes. Now, this is not all for telehealth. This includes meetings, planning meetings, administrative meetings, trainings, etc. And because we let everybody use it as they desire to use it, I can't really break out how much video conferencing is happening out with our tribal partners. But this also shows the usage in our system has doubled since 2015. We do provide a lot of different video conferencing based specialty consults from the Alaska Native Medical Center to our tribal partners. This gives you a list of the number of departments that offer video conferencing based services as of about 6 months ago, and the number continues to grow. I highlighted 2 here that I think are most interesting, and that is the adolescent medicine and the breast cancer screening. And this just demonstrates that in Alaska, as I'm sure it's the case in Alberta, we don't have all the specialties available within our state. And so we work with the adolescent medicine group down in the Seattle Children's Hospital, and we work with the Mayo Clinic to provide breast cancer screening for women that are high risk of breast cancer. And we continue to work with partners throughout the United States. Interestingly enough, we have one department, I think it's rheumatology, where we do not have a provider here in Alaska, and we do telehealth with a provider that is in Germany. So really, this is the beauty of telehealth. We can fill in gaps in our ability to provide care. We had a dermatologist for a number of years that then left the state, and we did not have a dermatologist, so we used a group down in Florida to provide dermatology services until we could backfill that position. So also allows continuity of care when you have gaps in your provider pool. One of the lovely things about using store and forward telemedicine, and because we wrote it, we added this capability, is to insert a survey tool. When we designed our system, I think this is true of most places, the providers were very reluctant to be involved in any kind of survey. They felt this was production healthcare. It was going to be how they delivered healthcare, and they didn't want to be evaluated constantly. But we did get an agreement to be allowed to ask one question every time a provider initiates a case, in other words, captures patient data and sends it, or when a person consults on the case, meaning they're looking at the data that was sent. So over the years, we've collected over 10,000 responses to a whole series of questions. So one of the questions is we asked them to rate the encounter in terms of improving the quality of care for the patient. And 3/4 of the time, providers say that telehealth improved the care of the patient over using a non-telehealth solution. And 2/3 of the time, they say it improves patient satisfaction for the patient. So this led us to a question back in 2011. At that point, we'd been running for about 10 years. We had a lot of users using the system. We had users that had used it for literally for the 10 or 11 years that we'd been running. And we really didn't know why they were using it. And I don't think too many telehealth programs go back and ask people 10 years later, why do you continue to use the system? So we did a study, and we did this in a partnership with the Ontario Telehealth Network, which is led by Ed Brown at the time. And we did a study to see if the users, the providers in Ontario, were similar to the providers in Alaska. We had providers that had been using the system for years, and we wanted to know why they were using it. So this is a study we did, and I did it with Chris Patrikowski, John Kokesh, and Mandy Constantine. And we had a number of providers in our system that we would call high users, people that had worked on 500 or more store and forward cases. So we had 22 providers that had created 500 or more cases. We called those initiators. And we had 49 that had consulted, in other words, responded to 500 or more cases. We had many more medium users. Those are in the 100 to 500 total cases. And then we had even more that were in the low user, 10 to 100 cases. So we surveyed them with a whole series of questions. And let me tell you what we learned. When we asked them, why do you do telemedicine? And we gave them a number of choices. We asked them to pick 3. The majority of the time, they would pick either it was best for patient care on the top, or it increased access to care on the bottom. About 2/3 of the time, those were picked by the providers as one of the top 3 reasons they did telemedicine. The bottom 2 reasons were it saves my organization money or improves patient satisfaction. Now that's not to say it doesn't save money or it doesn't improve satisfaction, but basically our providers were not using it because of those reasons. They did not consider that to be the top 3 reasons. The other reasons, helps me communicate, most convenient or whatever, were rated differently. And we noticed some differences between people that used it intensively, people that had used it for a number of years, or between initiators and consultants. And it's kind of interesting to learn the differences between the providers. So let's talk about those that said it helps me communicate with the doctor. Now this is pretty obvious. What you learn is that people that initiate a case said it helps them communicate with a doctor over 70% of the time. A consultant put it lower at about 35% of the time. But what's interesting is if you look at the high user initiators, the people that have done 500 or more cases, they say 86% of the time it actually helps them. But the high user consultants drops to 23%. And I think what happens over time then is the initiators start to really appreciate, as they use it more, how it helps them communicate with a doctor. And it becomes very important to them. So for initiators, people out at the rural areas, this is a very significant communication tool. When we looked at the reasons that would say it was either most convenient to the patient or makes me more efficient, surprisingly to us, was that consultants felt the convenience to the patient was the most important. The initiators did not feel that. So for the consultant, they actually appreciate the fact that this is providing a convenience to the patient. They also believe it makes them more efficient, and that makes sense. The initiator on a store and forward case has to spend some time taking pictures, documenting the information, and sending it to the consultant. So for some initiators, it takes a little bit more time versus the time it would take just to send that patient to the next level of care. But for the consultant, they are actually able to see these cases and make decisions, and sometimes it's a decision to travel the patient, sometimes it's a diagnosis or a treatment plan, but they can do it very effectively. And to give you an example, we went back and we looked at the median time spent by consultants responding to store and forward cases. And what we have in the top left is the data, the median time from 2002 to 2006. And you can see as we improved the software and as our providers became more proficient with the system, the median time dropped from around 7.5 minutes down to about 5 minutes, which means that most of the time, 50% of the time actually, they're able to review a case and respond to it within 5 minutes. And that is despite the fact on the lower right curve, we were doing more and more and more telemedicine each of those years. So as we used it more, we actually got more efficient. One of the things that we learned is this concept of, does telehealth give people confidence in doing the right thing for the patient? And this might be somewhat obvious, but you find low users of the system, people that have done less than 100 cases, find it does give them confidence. Not a lot, but about 25 to 30% of the time they gain confidence. The same is true for medium users, people that do 100 to 500 cases. But high users that have done more than 500 cases don't necessarily rate this as high. And that's actually pretty typical. What happens in telehealth is as users use the system, they're also learning. And they're learning perhaps what an infected ear looks like. And after a while, they don't need the telehealth system so much for confidence, and they use it for more corner cases or for other reasons. One of the things that we learned is how important the speed of reply is. Now, this is just the percent of users that said it was extremely important. And what we find is that for initiators, people that create cases, the ones that have used it a medium amount, say 20% of the time is extremely important, but the ones that have used it 500 or more times, almost 50%, about 43% say that it is extremely important. And what we've learned over time is that you build the system and you may not focus on speed of reply, you may just focus on getting a reply. But over time, the speed of reply becomes more and more important. We think, actually, we find that there are providers that will only do telehealth because they believe they can get a fast response. It's faster than any other options. So when you design a telehealth program, you really need to think about how you're going to get that speed. And it may not be something that you know ahead of time, and it may not be something your providers know they want ahead of time. When we look at our turnaround time here at the Alaska Native Medical Center, we actually find that 25% of our cases are turned around in 60 minutes, and more than half are turned around in the same day. That's pretty important, we think, and we'd like to kind of keep our eye on this number. What that means, though, if you think about it, is that we can provide a level of health care in a rural area or a remote area that may be better than the kind of care you can get in a major city. So for instance, if you walk into a village clinic in Alaska and you have a child that has an infected ear, there's a 1 in 4 chance that you'll get a response from a specialist about that patient, about your child's ear, before you actually leave the clinic in less than an hour. Whereas if you walk into a physician's office in town here and you need to go see a specialist, there's no chance that you'll see that specialist within 60 minutes. You may wait multiple days for that appointment. So telehealth doesn't provide the same level of care. I would argue that telehealth can provide a higher level of care through this access measure. So let me talk about access. One way of measuring access is turnaround time, but there are better ways to measure access. So I thought I'd give you some of the data that we've learned over the years. So we did a study in Nome where the Iditarod dog sled ends back in 2007, I believe. And we looked at how often patients in that area were seeing a specialist, specifically an ear, nose, and throat specialist. Before they implemented telehealth in 2001, they had about 200 specialty appointments, and that's back in 1999, and it dropped almost in half in 2000. In 2001, they had about the same number of referrals or in-person visits, but they added about another 100 telehealth consults. And then that number grew in 2002. And if you look at in 2006, they have about 650 patients being seen by a specialist, either in person or by video. Whereas back in 1999, they had 200. So they increased by a factor of over 3 the number of patients that were seeing a specialist, either virtually or in person. So that's one way to measure access, how many patients see a specialist. Another way to look at that, though, is how long do patients wait to see a specialist? And we looked at over 1,000 new patient referrals to the ENT specialist. And the way that works in Alaska is the patients either have to fly all the way into Anchorage, and from Nome, that's about a cost of $600 round trip, or they have to wait in Nome for a specialist to come out, and the specialists typically come out about every 3 months. Prior to telemedicine, over an 11-year period, over 1,000 patients waited to see a specialist. The 47% of those patients waited 5 months or longer to see a specialist. So almost half were waiting 5 months or more. Once we implemented telehealth, the next 3 years, the percent that waited 5 months or more dropped to 8%, and then 3 years later it dropped to 3%. So two things that we learned from this data. One is that clearly using telehealth allows us to reduce the wait time that patients wait to see a specialist. But the other lesson is that the true impact of telehealth doesn't necessarily get felt immediately. I mean, 8% was the impact in the first 3 years, but then we get almost a threefold drop in that number in the next 3 years. So telehealth sometimes takes time to know if you've really got the full impact. One of the things that telehealth lets us do is provide care in the patient's community. We have a huge focus in Alaska, like many other places, on creating patient-centered medical homes and supporting our tribal partners, such as the Norton Sound Health Corporation and Nome, to really take care of the patients and keep them in the village or keep them in their community. And telehealth lets us do that in a number of ways. We also tried some other things with telehealth. We had a number of patients that were waiting to see a specialist. And since we had the same telehealth equipment in every village clinic, we thought we could send out an audiologist to screen every patient that was waiting to see a specialist. So we traveled an audiologist out to see about 2,000 over It cost us $175,000. But in that process, we actually saved travel for over 1,000, over 1,700 patients, of which over 1,000 were children and would have traveled with a guardian. And we figured that that program saved almost $700,000 in travel costs. So it had about a 300% return on investment. But what's probably more important is that we tracked the outcomes of every one of these cases. And we found that about 72% of our patients needed something done and needed it done fairly quickly. If you notice towards the right, 27% of the patients needed surgery or testing in Anchorage at the Alaska Native Medical Center. So those patients got flown in very quickly to Anchorage without waiting to be seen at a field clinic or be seen by a specialist and then have to fly into Anchorage. We found that some were waiting for the wrong specialty, otolaryngology versus otology or whatever, and 6% were removed. We found 26% of our patients that were going to see a specialist really didn't need to see that specialist. So those patients were removed from the waiting list, and as a result, other patients got on that waiting list or got those appointments to see a specialist. So other patients got the benefit of this process as well. Another study that we did was to work with our diabetic patients. We've had a growing incidence of diabetes in the Alaska Tribal Health System, but we had a declining percent of patients that were getting a diabetic retinal exam. And as you probably are aware, diabetic retinopathy is a leading cause of new blindness in adults. It's completely preventable. It just has to be diagnosed. And if you don't have an annual exam, you can't diagnose the retinopathy that's occurring. So we started a program where we flew out a non-mydriatic camera. It's about a $20,000 to $30,000 camera that can look at the retina and take pictures without dilating the pupil. We flew it out in the middle of winter, towed it on dog sleds into each of the village clinics that we went to, and we would screen all the diabetics in the village. That was a 1-year pilot to see how it would do, and the results of the 1-year pilot were that we reversed a 7-year decline in the percent of diabetics getting an annual eye exam. It had dropped below 50%, and we were able to turn it around and go from a 25% decrease to a 15% increase in the percent of diabetics getting a retinal exam. We've done a number of other clinical care models, tried a variety of them. This is one that I just thought I would share with you, that we had received a request from the Yakima tribe in Washington State. They did not have any access to certain specialists, and they'd asked if we would be willing to be able to consult to their organization. Now, the patients were not going to fly to Anchorage for care, but we were helping Yakima decide if those patients needed to travel to Seattle for care or if they could be treated in Yakima. And just by doing that remote consultation, we actually estimated that we prevented travel in over 80% of the cases, and only a few then had to actually travel to Seattle. So, of course, one of the things that telehealth helps with is in reducing costs, and I'll share some data with you in terms of that. We actually tried to estimate travel savings in Alaska. We've done studies on Medicaid population and other populations. This is actually our total annual travel savings on an annual basis for all patients. We differentiate between primary care cases that basically go from typically a village clinic to a regional hospital, and specialty care cases that go from often a regional hospital into Anchorage. And you can see that the travel savings in the last year that I have data for, FY15, we had close to $4 million in travel savings for the primary care cases, and about another $6 million for specialty care, for a total of about $10 million in annual savings in that fiscal year. Our total savings since we began the program are running over $60 million. When we've done a similar study, but just limited it to Medicaid patients, and the reason that's important in Alaska is that Medicaid does pay for patient travel, we find that the Medicaid program saves about $10 to $11 in travel for every dollar they reimburse specialists to do consultations. So for the Medicaid program, it's a huge cost savings. And that's part of the reason that now the state of Alaska Medicaid program is going through a redesign and looking at how they can improve quality and access to care but reduce costs. And they've created a telemedicine work group that is specifically focused on how, as a state, we can improve care by looking at shared telemedicine solutions. The other thing, of course, that happens, there are other costs to healthcare when you travel a patient, and one of the most obvious is that for adults that are working, they'll lose work days, and for children that are in school, they will lose school days. And when we did this Medicaid study back in 2009, we looked at about 6,000 consults for about 3,500 unique patients. And we found that with 6,000 consults, we saved close to 5,000 lost days at work and about 1,500 lost days in school. So if you extrapolate that, that says that roughly every consult saves about a lost day at work for us, and about every 4 consults saves a lost day in school for a child. One of the other things that we see with telehealth is it improves processes and relationships. There are a number of ways that we can improve processes. One of the challenges in very rural areas is that it's oftentimes very hard to do follow-up on patients. A patient would be flown into Anchorage. They may get something as simple as ear tubes placed in their ear, and then when they fly back to the village or fly back to a regional hub, it's oftentimes hard for the specialist to be able to follow that patient. So we've done a number of studies. We did a validated model, double-blind model, where we actually tried to estimate if taking images of the PE tube and the tympanic membrane was as accurate for determining the status of the tubes and to determining the treatment plan, and compared that to how accurate that was to an in-person visit. And we looked at the comparisons between 2 different providers versus an in-person and an imaging. And we found out there were really no statistical differences. So we now do this routinely. We do, in fact, not just for PE tubes, we do a number of post-surgical follow-ups. Even in cardiology with heart patients, we do follow-ups over telehealth for those patients. We also found a number of patients that had, that we received images on those patients. We would then plan a surgical intervention for that patient if we felt it was merited. And those patients would, of course, get a full workup once they came into Anchorage, but typically they would be coming into Anchorage the night or the day before their surgery. And so the time would already be blocked off in the surgical schedule, and a procedure would be planned. So the question we had was, is using images as accurate in predicting operative time and operative procedure as actually seeing that patient, say, at a field clinic and making that decision in person? And we actually found there was no statistical differences. And this was doing a like-for-like comparison between in-person and telehealth cases of similar complexity. And some of these cases were significantly complex surgical procedures, but we found no difference. So we feel comfortable using telehealth to kind of plan the OR schedule around our patients that are coming in. One of the things that we're able to do with telehealth is to do things we never could do before. We have actually a fairly large percent of children are born deaf in Alaska. And in the past, those patients, those young children, would have to fly outside of Alaska to get a cochlear implant and spend a year about outside of Alaska going through therapy to learn how to use that implant. Now we can actually do the cochlear implants here in Anchorage and have the patients fly home and do all of the therapy over video conferencing. And in fact, all the therapies, speech and language, and physical therapy and other therapies are now being done over video conferencing to village clinics and in some cases to patient homes. So all this data and these studies really kind of lead to kind of one of the main conclusions that we look at telemedicine as a strategy to improve access, quality, and performance, and to manage cost and risk. It's not the only strategy, but it's a very important strategy for us. Which leads us kind of to the thought about, well, we've been using it for 15 years here in Alaska, how do you sustain a system? And I think the symptoms of a sustained telehealth system include that it's embedded with strategic health plans. So our partners, our payers, our leadership are all convinced of the value of telehealth, and they make it part of their corporate strategy, not only just in the healthcare realm, but in the strategy of working with the payers to get paid appropriately for telehealth. It's supported by corporate policy. We have tribal partners that actually say, under certain conditions, you will create a telehealth case and you will send it. It's mandated in certain areas. A sustainable system, of course, has full reimbursement for that. But one of the two other things that are symptomatic of a sustained system is you start to be challenged by scale. And what I mean by that is that when you do 20 or 30 or 40 consults in a month, it might be one a day. But when you start to do 1,000 a month, it gets into enough of a day that you actually have to plan your workforce and you have to plan time for people to do this. You have to understand how you're going to, what your response time is. You come up with service level agreements. And so the scale issue drives you in a very interesting direction. And we were challenged by scale early on. I think at this point, most of our scale issues have been resolved, but it is a problem that you have to face. And then integration. More and more integration with the electronic health record has gone from a nice to have to a must have. I'm going to talk about that for a few minutes here. This is a slide from the Office of the National Coordinator for Healthcare IT in the United States, and it shows the percent of hospitals, non-federal acute care hospitals, with at least a basic EHR or a certified EHR in the United States. And when we started implementing telehealth back in 2001, some of our sites had an EHR, some didn't, but it wasn't really that critical to be integrated. But now everybody pretty much in the tribal health system has an EHR, which is pretty much true across the United States. And because of that, the EHR integration is becoming more critical. It's also becoming more critical because we want to use the EHR differently. And Henrik talked about this, the idea of being able to understand your patients better and have the data in your healthcare informatics system and create better analytics, to turn that data into knowledge and to turn that knowledge back into improving the care of your patient and the health of your patient. So telehealth is part of that, and it needs to be integrated for that reason. We face a challenge, but it's an interesting challenge in the Alaska tribal health system. And the challenge is that over the last several years, we have had more and more of our organizations moving on to a single unified electronic health record. We built out a Cerner electronic health record here at the Alaska Native Medical Center in 2011. And over the next 3 years, we had 3 different organizations join, one each year. But now it has taken off. And this year alone, we have 8 organizations joining our system. And we already have organizations signed and confirmed to deploy in 2017 and into 2018. And what that means is that when we're on one single system, it gives us the ability to think through how can we integrate our telehealth system into that Cerner technology. So it helps us focus on what the integration efforts need to look like. What that means for our telehealth program is you have to create this version EHR kind of solution. And we have to go from a standalone system that was available in mobile and web-based platforms into something that uses the EHR technology. It uses what's called CAM, which is the kind of the storage mechanism in the Cerner system. It uses M-Page technology to present it and create a mobile platform. We are well underway in that effort. Our program continues to work on it, and we realize the need to make this happen. I will say that an EHR is not necessarily a telehealth solution. An EHR is an EHR, and we are working very hard to bring those two things together and make them work seamlessly. Now, it's not just us that's doing this. This is a major EHR vendor's approach to telehealth. I won't say who it is, but I can tell you that 3 major EHR vendors, including the 2 most popular in the United States, have already integrated video into their EHR, and they plan to offer, or they already have offered, e-visits, so patients can get onto a portal and talk to a provider. Provider-to-provider video will be coming soon. This particular vendor has a number of solutions, including e-visits available. They're adding remote monitoring, I think something that Henrik was talking about, and they're adding video. So we're already seeing these worlds kind of moving together. And I think what we're actually seeing when I step back and look at how the world of healthcare is moving is we're starting to see telehealth becoming a commodity. In some places, it's already a commodity, meaning that there are many health plans, many provider or corporate health plans that make telehealth available to their employees. There are companies throughout the United States and actually throughout the world that will offer immediate video consults or immediate phone consults with patients that need it. In Alaska, or in the United States, the state of Massachusetts offers it to folks that live in that state. So you're already seeing it become kind of mainstream and a commodity. We're actually already beginning to see it becoming a blended visualization. So the idea of store and forward and remote patient monitoring video is really becoming just one ubiquitous system where all that is integrated, hopefully through the electronic health record. So the data is there to make analytics, but it's completely available to the providers when and where they need it. We're seeing the development of lightweight platforms that run on iPhones, iPads. We don't need dedicated systems to this. And then the trick is to leverage large-scale infrastructure. So master person indices. So when we send telehealth consults between different organizations, we can actually do lookups and find the appropriate MRN, medical record number, to put the data into the EHR appropriately. So this is already happening, and I think it's going to happen more and more in the future. And so that's kind of my prediction of where this is headed. The state of Alaska has a number of telehealth systems. We're not the only one. Our primary focus is in the tribal health system. But as a state and through our Medicaid redesign, we're actually working now to think through how can we work collaboratively. And it's not just the people that do telehealth, it's the people that work on electronic health records, the people that work on the health information exchange. We're trying to think how this all fits together, basically to improve the quality and access to healthcare and decrease the cost. I'll finish with this. This is the village of Stebbins. They had a fire in their village clinic many years ago. I think this was around 2005, but the clinic started to burn in the winter, and it was impossible to pump water to put the village clinic out because the water was frozen. It's in the middle of the winter. It was probably about 30 degrees below zero Fahrenheit. So all they can do is bulldoze the clinic to prevent it setting fire to other buildings around it. What I thought was interesting, though, while this clinic was burning, the staff ran into the burning clinic and they rescued the telehealth cart and brought it over and plugged it in at the school the next day and sent us a picture to show us that they had saved the cart and that it worked. So my staff were very happy it worked, but I think what I find most amazing about this story is that shows the value of telehealth to providers when they'll run into a burning building to rescue the equipment that lets them communicate and talk to providers in other parts of the state. So I'll finish with that, Ted, and turn it back to you for questions. And thank you.
Well, that was wonderful, Stewart. And you know, folks, if you hover your screen and find the Q&A, post some questions there. But while you post questions, Stewart, I was really fascinated with some of your comments about, it was about rural and remote communities, healthcare actually through telehealth being sort of better than they were before or better than urban. Did I get that right?
Well, that was my point. And the issue is there have been studies that have been done, and I can't remember the date, I quoted them some years ago. There have been studies that look at wait times for patients to see specialists. And the studies were done in Washington, D.C., New York City, Los Angeles, Chicago, major metropolitan areas. and they were done for different specialties, pediatricians, otolaryngologists, dermatologists, etc. And the wait times are staggering. I think the average in many of those cities, major cities, is 5 to 10 days to get into different specialists. And my point is that telehealth can knock that down to an hour or less. And that's an access model that you can't get. You can't get that in Washington, D.C. And so in that sense, it provides access that's unparalleled, I think. And I love the idea that we can provide better access to somebody living out in the Bering Sea on an island than we can provide to somebody living in New York City. It's just powerful.
Well, and the other thing that I would comment, just so that you know, I mean, over a period of about a decade, Alberta invested a lot in a province-wide internet-compatible network we call SuperNet, you know. And at the same time, there was a heavy investment in the H323 video conferencing. But it's kind of like what I'm hearing from you is that this is sort of a new world. I mean, a lot of our old video conferencing gear is sitting idle, but things like video and Zoom that we're using now and others, it seems like it's a new context.
It is, and it's not just a video conferencing, but the video conferencing technology, and you and I talked about this earlier today, has changed dramatically. And I think the world of $10,000 endpoints has completely gone away, of course, and the $100,000 bridges, and the systems are very simple. We've built out a system that we use in the tribal health system, but I'm hoping it's something that we'll just kind of start to use on a statewide level in Alaska. But it allows up to 20,000 users on the system, and it allows everybody to connect. And it's the same as what we're using in Zoom. It's desktop video. Anybody with an iPhone, an iPad, a tablet, or a PC can connect. And you know, these systems are designed to work over low bandwidth. That's what's really powerful. So we can start to go into homes, patient homes, where they may have a pretty weak cell connection, or go out to clinics where we have long delays over satellite. And this system seems to work very effectively. So it's almost like somebody developed the right system finally for use in rural and frontier areas.
Yeah, well, you know, and we have rural, remote, and what I would say probably in common with Alaska is remote work camps for oil and gas workers. So I think we have a lot of commonalities, Stewart.
Yeah, I would not be surprised at all. One of the things that's happening in Alaska is that we're finally being able to get cell connectivity into some of our villages. So people can get cell phones, but then that makes us think, what can we do with the cell technology? And we're probably behind a lot of the lower 48, the other states, because they've had this into people's homes for years. So we're interested in things like what Henrik was talking about, where we can help manage and monitor patients and take care of our chronically ill. So we're hoping to kind of do more of that, I think, is in the future.
Well, I mean, this has been a fascinating presentation, and you know, the similarities between Alaska and Alberta and the challenges that large geography and low population density presents. And it's wonderful to see this example where you guys are kind of, you're creating stuff that responds to that context.
Yeah, exactly. And you know, we've partnered and shared information with Canadian provinces for years, because we do find we have so many similarities. And it's exactly what you talk about. You know, the doctors are not where the patients are. It's a maldistribution, right? It's not only a maldistribution, we're underserved in many ways, right? We have a very high ratio of family physicians in Alaska, but a very low ratio of specialists. So telehealth is kind of a force multiplier. It lets a specialist see more patients and see them across a larger area. It also allows us to bring in specialists from outside. So it's really the only thing we have right now to try to take care of some of these challenges.
Well, and when I was checking out your organization, Stewart, I was pretty impressed with, it seems very progressive and looking at innovative solutions to overall health, like water and sewer and all kinds of different things.
Yeah, you know, I work for an amazing company. The Alaska Native Tribal Health Consortium is quite amazing. It doesn't just manage a hospital, it manages an amazing hospital. We're We're the first level 2 trauma center in the state. We're the only magnet hospital designation for our nursing program. It's a wonderful hospital. But we also have a group of hundreds of employees that work in our Department of Environmental Health Engineering, and they design and build clinics, water systems, sewer and sanitation. We still have a number of villages in Alaska that don't have running water. So they help build those systems out. They help with power, and they're working on sustainable energy now in some of the village clinics because the cost of fuel, of course, is very, very high in those areas. So we look at health as a much bigger system than just health care, right? So my company actually has this vision that Alaska Natives will be the healthiest people in the world, and I think that the goal there is that you have to take care of everything, right, as much as you can. And
well, and you seem to mention that you guys are using the system for kind of like the mental health side of health.
Yeah, so the company I work for, ANTHC, doesn't specifically offer behavioral or mental health services, but we have a number of partners that do. Our hospital is co-managed by a company called South Central Foundation, who won the Malcolm Baldrige Award for Excellence a couple years ago. They're an amazing company, very data-centric, very smart, and they have providing behavioral mental health services in an integrated care plan, and they're beginning to use more and more video for that. We have a lot of tribal health partners in Alaska that have mental and behavioral health programs, and many of them actually use telehealth, and they partner with other telehealth providers throughout the state. So it's a growing need, but it's also something that's growing in terms of telehealth services throughout the state.
Well, the reason that I mentioned that specifically, Stewart, was because we in Canada, we have some remote Indigenous communities where the rate of youth suicide is absolutely horrible. And when I saw through the research that you guys were sort of doing that as well, that's why I wanted to talk to you about that.
Yeah. You know, we have a number of statewide programs that are using telehealth. I think we haven't quite. We're scratching the surface in some ways. I think depression, suicide prevention are two big areas. Drug and alcohol, support. Also, supporting our sexual abuse response teams. And so there's a lot of programs that I think can benefit from using telehealth. I'd say we haven't fully figured it all out, but I think we're on the right path to put this all together.
Well, I guess the other question that I would pose to you is there a consulting arm of your organization?
Not really. We have a telehealth program, the ANTHC telehealth program, that has about 20 staff, and they work and provide telehealth solutions throughout the entire tribal health system at no cost to the tribal health system, except when there's equipment, they have to buy that equipment. But we develop software, we develop programs, we build programs, we do training, and so forth. We do. We recognize that we have been funded by the Indian Health Service, and so we've had a lot of partnerships with other tribal communities throughout the United States, and we have a partnership. We've been working with the state of Hawaii on some of their work. So we do partner and work with a lot of people, but we don't have a formal consulting group at this point.
Yep. Well, Stewart, I haven't seen any questions, but this presentation, both presentations have been absolutely wonderful. And what I was going to suggest for remaining 7 minutes or so, if Henrik is still online, if he'd like to join us, and if you guys would like to sort of chat about where you see telehealth going in the next 5 years. I don't think I want to open up a window any more than 5 years, because I think that's unrealistic. But in the next 3 to 5 years, where do you guys think things are going? And I'll open it up to Henrik first.
I think we're going to see a more specialization in what we're doing. As you see that as Stewart is mentioning, that the features and functionalities of the systems we're using, they become more intrinsically able to do stuff by themselves, like video, and this becomes like a commodity. Mm-hmm. So while services that today are making up a very large part of telemedicine, like video, becomes a commodity, then you start focusing on where's the added value. And now you will see a commodity turning out to be video, and you will have a more well-defined interface for video, so you can add more, like Zoom would be a component to add, which should be very easy once it become more web-enabled. So with the new interfaces, we are able to add more stuff. So we became more specialized. So I think we will see telemedicine branching out to diagnostic platforms like the one Stewart is using, which is a very important stuff when you have so much geography. You will see a specialization like the one I have, which is a component for remote monitoring and prioritization of effort, because that creates value for some specificities. So yeah, I think you will see a dissolution of the systems into components, where suppliers like Vivify and other big solution providers that are feature complete will be dissolved into parts where you have specialized companies building those, because if you have to spend a lot of energy on building every piece of feature in this complete solution, then you cannot build every one of them well enough. So you have to prioritize. And the solution to that is to allow someone else who has specialized knowledge and specialized skills to do that for you and add it to your solution. And this is a development we've seen on all the areas of IT, enterprise architecture, and other kinds of solutions. So this is going to happen in healthcare as well. It's just a bit more heavy because there's a regulatory part to it, but we'll see it definitely.
And Stewart, what's your take on the next 3 to 5 years?
Well, it's going to be really interesting. The thing that's changing right now, at least in the United States, is we're shifting from fee-for-service to value-based purchasing, and the way that we're moving, we're kind of shifting from meaningful use reimbursement and incentive payments to a whole new model called MACRA, and it has some scoring there, and it's kind of a quality scoring for hospitals on how well they provide care, and that's going to drive Medicaid reimbursement. And Medicare is going to hold up to a plus or minus 9% swing in payment to organizations based on how they do in terms of quality care. And telehealth is probably going to be driving a lot of that, especially the high-cost patients. We're going to be starting to do much more remote management of those patients. We're going to be looking at telehealth as a way to stop 30-day readmits of patients that have been in the hospital and so forth. So our payment model is going to drive a lot of organizations to think about how they're going to do it. We already see, I think it's Mercy in the lower 48, have built out a 300-room, I think, facility that has no hospital beds. It's a virtual care center, right? We have a number of service providers that are now covering in the millions, the tens of millions of patients throughout the United States. And so I think population health, payment models are all going to drive us to think differently about this. One of the things that's interesting to me is that telehealth has always been challenged to show it's as good or better than in-person care. And there's never been really good metrics for that. There have been no national standards for that. And so I'm now on a committee by the National Quality Forum in Washington, D.C., where we're trying to figure out what metrics are out there right now that can be applied nationally at the federal level and by federal agencies to measuring the quality of healthcare delivered by telehealth. And that's new, and that's really wonderful. So now the federal government, the payers, the payment models are aligning behind the fact we have to do this. I mean, it's not even a question. EHR vendors are going to provide the solutions, or those that have their own solution will be integrating with those. I think the big issue that we still face, though, it's everywhere, is the licensing and credentialing issue in the United States. Cross-state licensure is still an issue. All those companies that provide services are still getting licensed in multiple states, sometimes 30, 40 states to provide healthcare. Those are barriers. They're serious barriers. And once those start to come down, then it does level it. And I think maybe in 5 years, I'm not optimistic it'll happen in 3, but I think it'll just be healthcare. Is how we take care of patients.
Well, thanks so much, both Henrik and Stewart, for joining us. And I guess what I would like to extend to both you guys and our audience is, a safe and happy Christmas break, and just the best wishes. And thanks so much for presenting into this series.
Right.
Thank you. My pleasure.
Thank you. Same to you, Ted and Henrik.
Yeah, you too. Yeah.
Yes. Have a very Merry Christmas.
You too.
Bye.
Bye now.
Bye.